Ohio Department of Mental Health and Addiction Services Director Dr. Mark Hurst and Public Safety Director John Bourne are part of the Kasich administration's front lines, managing the money spent on Medicaid, law enforcement, and other services and programs. Thank you both for being here. I appreciate it.
Thank you for the invitation.
So, Dr. Hurst, let me start with you. The IMD rule, the Institutions for Mental Diseases rule, prohibits the use of federal Medicaid financing for care provided to most patients in mental health and substance abuse disorder residential treatment facilities larger than 16 beds. So I want to start with that. What has the Kasich administration done to help treatment centers with this rule, and what needs to be done on the federal level?
Well, a lot of that has been done as part of the Medicaid behavioral health redesign in terms of looking at the entire behavioral health benefit that exists. The roots of our previous benefit system were really 20 to 30 years old. So we really have needed to update that benefit to have it be compatible with the modern billing system and modern treatment being able to be rendered. And the importance of that is that our healthcare system and our reimbursement system is really moving toward evidence-based reimbursement. What we have done for years is really just pay people for the provision of services without regard to outcome with that. And we know that certain kinds of treatment are more likely to yield positive outcomes. So if we reimburse for outcomes in addition to reimbursing for the service, we should get better results down the road. So it's really bringing the payment system up to date in conformance with modern methods. In terms of the residential treatment, that is something that is being addressed and has been addressed within the behavioral health redesign. So at this point, individuals who enter residential treatment can receive in Ohio up to 30 days without any prior authorization. And then after that, there's some prior authorization that's necessary. But I think I also want to be really specific about the treatment of addictions and specifically opioid addiction. This is not merely a bed issue. Addiction is a chronic disease and it needs to have chronic treatment. So depending upon the level of symptoms that a person is experiencing, they may need more or less intensive treatment. So they may need residential treatment for a while, but this is a lifelong disease and they need to be attentive to that, and their treatment providers need to be attentive to that and dial up and down the treatment intensity as their disease is being expressed at any point.
Now, I know you're relatively new on the job. You took over for Tracy Plowk earlier this year. The state has talked long about spending $1 billion toward the opioid problem. Where is that money going? I mean, is most of it going to treatment? Is most of it going to wraparound services? Where is it all going, and has much changed here? As the numbers keep going up, has the state proportionally responded?
I believe so. And, let me clarify a little bit. Although I'm new to this job, I'm not new to the system.
But yes, of course.
So I'm an addiction psychiatrist, actually. So I've been the medical director for the department for 6.5 years before assuming the responsibility as director in the past couple of months here. But you're right, it's about $1 billion that the state's spending on the opioid epidemic. A large part of that is Medicaid funding for treatment services. And in fact, well over half of it is for that. But in order to deal with this effectively, we need to have a multi-pronged approach with that, which includes prevention, early intervention, or being able to identify the issue before it becomes an addiction, effective and evidence-based treatments, which includes both the counseling approaches and medication approaches, and life-saving measures such as naloxone. And all of those are represented in the funding.
Let me turn to you, Director Bourne, and ask you, we've often heard that we can't arrest our way out of this, though there's been a lot of emphasis on what law enforcement can do here. What can law enforcement do, though? I mean, when you're dealing with people who have an addiction, a problem, I mean, you do have drug dealers and people who you can arrest for crimes, but what about people who are addicts, who are struggling? Well,
it's a great question. In 2011, we shifted the entire focus of our law enforcement efforts in Ohio, and particularly with the Ohio State Highway Patrol, and began focusing on supply lines. We knew that because of Ohio's interstate network, because of our location geographically, that we were a key center, and so we began looking for ways that we could interdict the supply so that we could both disrupt the supply, and you note that I didn't say stop the supply, but disrupt the supply, increase the cost, and increase the risk. And in the last 7.5 years, we've seized more drugs than ever before. And some of those seizures, you think, okay, well, it's not having any kind of an impact. Well, if you seize 16 kilos of fentanyl, as we did out of a traffic stop, that's literally hundreds of thousands or millions of lives that have been impacted that night. Now, long term, as the doctor said, the key is on the demand side, and not only the people that have entered that unfortunate cycle of addiction, but trying to keep people out of that first use, and that really is the key. Law enforcement plays a critical role, not only in obviously the interdiction and the supply line, but in the education efforts as well. And so we began a program called 5 Minutes for Life. It's just one of the programs within the Start Talking campaign that the governor and the First Lady initiated, and that was to try to stop that first use, because we know if we can prevent the first use, that we can prevent the cycle of addiction that follows.
Now, we had a situation in the Ross Correctional Institution not too long ago. 29 people were exposed to heroin and fentanyl, and it's still under investigation. But that shows that there is a situation involving the prison system. We know that people are coming into the prison system who have drug issues. What do we do about that?
Well, I think it illustrates the challenge of trying to affect the supply line. You know, the patrol's still conducting an active criminal investigation on the circumstances of that particular case. I think by and large, it's extraordinarily difficult to get drugs within the institutions, but difficult doesn't mean impossible. We also know that 80% of the drugs that we're seeing in Ohio are coming across the southwest border. And I've been there, watched it. It comes across in the traffic that's moving. Literally tens of thousands of vehicles a day are coming through. And so while you can make an impact on the supply, whether it's an institution or to our cities or communities, really what you have to do is reduce that demand. The cartels and the other organizations that are moving these drugs will simply follow the supply and demand model. We've seen that, for example. We've had significant impacts not only on individual loads that are now being moved around Ohio or avoiding Ohio, the size of loads, which have got smaller by vehicle because they don't want them interdicted. But we're also seeing now a diversification of the types of drugs. We're seeing much more methamphetamine being moved in Ohio, and that necessarily isn't a good thing, but it does mean that we're having an impact both on the treatment, the prevention, education, and on the interdiction.
That brings up what I wanted to transition to. I mean, even though you're stopping some of these drugs coming in, these numbers have still been going up from 2016 to 2017. They went up, and the CDC has predicted they'll go up another almost 10%. It appears the problem is fentanyl, that it's showing up in cocaine, it's showing up in meth, it seems like the state has gotten a handle on prescription painkillers and somewhat on heroin, but fentanyl is really the problem.
Yet fentanyl is so much more potent than the other opioids, and it's not only potent in terms of its psychological effects and its stimulating and its euphorogenic effects, it's also more potent in its lethal effects. And that's really a reflection of the progression of disease. So, individuals move as part of their addiction, they move to more potent drugs. And heroin's more potent than pills are. Fentanyl's more potent than fentanyl, and carfentanyl's even more potent. So you're exactly right. But you're also correct in terms of the direction in terms of prescription drugs. So we've seen for 5 consecutive years now a decrease in prescribing. We've seen a decrease in prescription-related overdose deaths. And the importance of that is that frequently those prescription drugs are the route to illicit drugs. So by intervening on that, down the road, we should have more effects downstream and less individuals who are using illicit drugs and less dying from that. You
mentioned that a lot of the money, the $1 billion that the state is spending, is going to treatment through Medicaid. We found out from Medicaid expansion earlier this year that about 8% of people who are in Medicaid expansion got Medicaid-assisted treatment at least once through the program. That just seems low. Are you reaching all the people that you feel need to be reached?
Well, I think we need to have more uptake of evidence-based treatments. And in terms of medication-assisted treatment, there's no question about the effectiveness of it. It cuts the likelihood of a lethal overdose by half at least. It improves the likelihood that people are going to be retained in treatment, that people are going to be employed, that decreases the likelihood of incarceration. So this is something that works. And all 3 forms of it, the Vivitrol, Suboxone, and Methadone, all are effective treatments.
But these aren't drugs that can be taken once. I mean, they're courses of treatment. You have to, if you're on these courses of treatment, have to keep going back and keep having them administered.
Yeah, I think I need to fall back to what I said earlier in terms of this is a chronic disease. So we need chronic treatment for this disease. So just like if you have diabetes, you need to have treatment for the diabetes for the duration of the disease. It's the same for addiction. You can't have one dose or one brief episode of treatment and expect that everything's going to go well with that. It needs to be sustained over a period of time to have the best likelihood of success.
Now, one thing that the state is doing, and when it comes to medication, is an immediate one, and that is naloxone, or Narcan, the anti-overdose drug that revives people. I want to ask you, Director, the state has been running a campaign to try to get people to have it in their house, to carry it with them. It's not free. How do you convince people that they should be spending their money like this when first responders have it, when it's available other places and people think, well, it's not in my house?
Yeah, well, the Division of EMS, which is a division within the Department of Public Safety, tracks all naloxone or Narcan administrations by all EMS providers. And last year, I think there were around 41,000 administrations. Now, that may be slightly misleading because in some of the cases, especially with fentanyl or carfentanil, you're seeing more than one dose administered. Really, the bottom line is that you're saving that person's life for that moment. And then it's really, really important that the next steps follow. And obviously that sometimes becomes a challenge. Some of the people that are in this cycle or at this point in the cycle want to take their life to the edge for that feeling that they're getting. And Narcan is really about the only effective way to bring them back from the edge. Not only is it important for people, but we've seen it for first responders as well, where we've had to administer that. And obviously we saw that in the prison where we've had to administer naloxone. So the good news is that as we measure lives, and we measure lives one life at a time, whether it's a traffic fatality, whether it's an overdose death, is that if we can save that life for that moment, there's hope. And so that's actually how we are measuring progress, not success, but progress.
And you just talked about once you get people back, then you have to try to turn them toward treatment. How is law enforcement capable of doing that? How does that happen where you find a way to put these people on the path toward recovery?
Well, that's a great question. We see what I would say national models of where law enforcement, mental health and addiction services, and treatment people are working together, these first responder teams. So law enforcement's jobs obviously become much more difficult, but having those other professionals with us. So in many cases, for example, I'll just give you one example. We run what we call SHIELD details, where troopers, federal agents, county deputy sheriffs, police officers.
A strike force?
That's right. And so they're going into a community to try to make a difference. And in those cases, when an arrest is made, we will have treatment and prevention people embedded with us that can immediately intake those people and begin the next step beyond that life-saving hope that they get on the.
But unfortunately, all communities can't afford that. I know there's one happening in Northeast Ohio, but there are a lot of communities, especially these smaller rural communities, that can't quite get that to that level.
Like I said, I think there's collaboration is probably the key, and I think there's some pretty good national models out there of collaboration of where law enforcement and those treatment professionals are embedded together. Obviously, it's an overwhelming challenge, both nationally and in the state. In Ohio, obviously, because of the pill mills and some of the steps that preceded this challenge, was on the forefront of it. But at the same time, I think other states are looking to Ohio on the successes that we've had on how you fix this long term.
Go right ahead.
No, Karen, if I might interject
Sure.
on that, we've been really fortunate the past several years to receive federal funding, first through the 21st Century Cures Act and upcoming through the State Opioid Response Grant. And part of that has been the development of rapid response teams to overdoses throughout Ohio. Now, not all communities have them, but these are clinicians or peers who will respond to the site of an overdose or respond to an emergency department to help intervene with that individual and try to influence them to get treatment very quickly at that point. Because that near lethal overdose is something that can impact someone and make them more receptive to pursuing treatment than they might have been at another time. And that's really critical for us to intervene when they have that motivation.
I want to ask you a couple of rapid fire questions here. Is it time for the state to have some sort of an office that deals just with the opioid crisis, an opioid czar, so to speak?
I don't know that the solution to this lies in one person. I think the solution to this lies in collaboration between numerous groups of people. And we have that with the Governor's Cabinet Opioid Action Team, where all the human service agencies, Department of Public Safety and other, meet on a regular basis. We have calls weekly, we have meetings monthly, and we interface frequently between that in terms of what approaches we're taking and how to integrate all of that. And perhaps even more importantly, on a community basis. We have a number of communities that have made really good progress in the past year in terms of reducing overdose rates. And those are the communities that have come together with all these kind of organizations and owned the problem and taken the resources that are available from the state and their own available resources internally to really have an effect on this.
And finally, real quick, two more. Needle exchanges, good idea?
Needle exchanges are one part of a comprehensive approach. We have to have that comprehensive approach. The evidence about needle exchanges is that if people are involved with that, they're less likely to transmit infectious diseases, and they're 6 times more likely to enter treatment.
And finally, on that, marijuana. We're in the process of putting, well, actually the medical marijuana programs out there now. Is marijuana a potential solution here?
Is it part of the solution? That's a great question. So the evidence about medical marijuana having an impact on the opioid epidemic, I would say, is equivocal at this point. There are studies that go in both directions with that. We're going to keep a close eye on that in Ohio to see what impact it may have.
And finally, this question's for both of you. Is the state doing enough to try to get a handle on these numbers? I mean, like I said, the CDC said that they're going to go up 10% this year, or predicted that they would. You've got it in every county. Every county has experienced at least one opioid overdose. Is the state doing enough? And I'll start with you, Doctor.
Well, when we have people who are dying, we obviously need to keep doing what we're doing. But this is a major public health issue, and it requires that broad approach in terms of the prevention, the early intervention, the treatment, and the life-saving measures that are available. We've done a great deal in all of those areas, and we're going to be trying to do more with this with our upcoming funding and our upcoming approaches with it.
So we've made what I would say is significant progress, and we're seeing that in some of the overdose numbers for example, heroin or prescription opiates. But this is a long-term chronic challenge. Just as traffic fatalities, we've had the 7 safest years in the history of Ohio in the last 7 years on our roads and highways, yet we still lose 3 people a day, every day, on average in Ohio. And so you really never declare success until you get to the point where you're not losing anyone. But I think people should be optimistic that the progress we've made will continue and hopefully accelerate.
And is there any need to declare an opioid emergency in Ohio?
I don't know what more we would be doing by doing that. I think that it's very clear that the opioid use and the problems associated with death are a crisis in Ohio, and we're responding in a crisis kind of manner. But I'd also like to project some hope here, because we have thousands and thousands of individuals who are successfully recovering from addiction. And this month of September is Recovery Month. The things that get people into treatment are usually bad things that have happened in their life as a result of addiction. But what keeps people in recovery is hope. And those tens of thousands of individuals who are working in active recovery program and having success, we need to look to them, because that's where our hope is and that's where our solution is going to be.